Okay, good afternoon, everyone. I am Lies Rombaut. I'm a physiotherapist and senior researcher in the field of Ehlers-Danlos syndrome and hypermobility spectrum disorders at the Center of Medical Genetics of the Ghent University Hospital in Ghent. I'm pleased to talk today about physiotherapy practical tips for joint hypermobility-related disorders. Okay. So I will start to explain you the landscape of joint hypermobility, followed by what is known about physiotherapy for patients with hypermobility-related disorders. And then in my major part of my talk, I will try to answer the following questions. Questions patients often ask me in the Center for Medical Genetics. The questions are, what can I expect from physiotherapy? How should my physiotherapy sessions look like? Should my physiotherapist be more careful and why? Which types of exercises are good and which ones are not? Can I use tape, splints and braces and when do I use them? And which sports are good and which ones not? Okay, so let's get started with the landscape of joint hypermobility. If you look at the global population, you would see that the range of motion, I hope the laser doesn't work, I guess. No, it would be helpful. The laser? It doesn't do anything. Thank you. This one. Okay, thanks. So if you look at the global population, you would see that the range of motion is distributed in a Gaussian way. Yeah? If this is the mean range of motion, many people will be around that mean. So that means normal mobility. And a few people, have a very large range of motion, the so-called hypermobile ones. A hypermobile joint can be defined as a joint whose range of motion exceeds the norm for that individual, but taking into account age, sex, and ethnicity. And we name it generalized joint hypermobility if the hypermobility occurs in 5 or more joints of the body. Okay. According to the 2017 classification, you should consider joint hypermobility as a spectrum. On the one hand side, you have subjects who are hypermobile, but without any complaint. So they are asymptomatic. Yeah? They are, in fact, healthy subjects. And hypermobility can occur in multiple joints or can be more locally. Yeah? In this group, there are people whose parents are hypermobile, and because of that, they are hypermobile too. So likewise, you have families with almost everybody having rosy hair. Yeah? The basic can be familial, and is most probably multifactorial and, that was too fast, and polygenetic. Yeah? On the other hand, in this group, you also can have patients who are hypermobile because of training, which is often an asset to be very excellent in certain sports. Yeah? And this is called acquired hypermobility. On the other hand, end of the spectrum, over here, yeah, you have patients who are hypermobile, most often in multiple joints, and which have often associated complaints such as chronic pain, joint instability with recurrent subluxations or dislocations. And moreover, and very important, they have multiple signs of tissue fragility. This kind of joint hypermobility fits into what we call syndromic hypermobility and fits into the heritable connective tissue disorders such as the Ehlers-Danlos syndrome, Marfan syndrome, and osteogenesis imperfecta. The cause of this hypermobility is lying in defects in genes encoding for connective tissue. Excuse me. And finally, we have in the middle, patients who have symptomatic joint hypermobility because they are hypermobile. They have hypermobile in multiple joints or in some joints, and always associated with pain and joint instability features. But, and that's the difference, they have no or less signs of soft tissue fragility. And therefore, they are labeled as hypermobility spectrum disorder. Okay. So to be clear, there is no difference between patients with hypermobile EDS and patients with HSD or hypermobility spectrum disorder regarding pain, also regarding hypermobility and the associated features like subluxations, luxations can be similar in both groups, but the difference is the degree of soft tissue fragility, especially those shown in these figures here. Regarding physiotherapy treatment, the approach for patients with hypermobility spectrum disorder and patients with EDS or hypermobile EDS is the same. That's important to know. So, what is known about physiotherapy for EDS and HSD in literature? Actually, not much. The literature regarding this topic is very scarce and nearly not evidence-based. However, what we do know is that physiotherapy is generally accepted as an efficient treatment for musculoskeletal complications of HSD and EDS. And as such, the physiotherapist actually has to play a major role in the treatment of the patient. There is some evidence that HSD and HEDS will improve with exercise, but there is no consensus. It's not clear which type of exercise is the best. We know also from clinical practice that there are many understandings regarding physiotherapy, such as only isometrics you can do to strengthen, manipulation is forbidden, do not stretch, bracing and taping is not good, and muscle strength only increase my pain. I hope I can show you with this presentation that it's not that clear-cut. Okay, so what can I expect from physiotherapy? First to be said, hypermobility cannot be cured. Yeah? So hypermobility or hyperlaxity means that the ligaments and the joint capsules are too loose, too lax, and there is no way to strengthen these ligaments. Yeah? But physiotherapy can have a positive effect, and especially in terms of less pain and a better joint stability. Let me explain now to you the mechanism of joint stability. It's important for the further part regarding the exercises. So the concept of functional joint stability comprises 3 subsystems. We have the passive subsystem, the active subsystem, and the control subsystem. And they're all working together to maintain or restore the stability of the joint. Let's take a look first to the passive subsystem. And there, the ligaments play an essential role. So in a normal situation, it is the task of the ligaments to let the joint move correctly. Yeah? But if your ligaments are too loose or not tensed enough, many problems can arise. I will show you. On the left side, like this, one problem that can arise is just that you can move further than normally. So that is called hypermobility. Yeah? Or, and that's in the middle, it is possible that the roll and glide movement, I know it's more technically now, that the roll and glide movement in the joint do not occur simultaneously, and because of the looseness of the ligaments, and this leads to subluxations with clicking and popping of the joints. I will try to demonstrate it like this, and you can hear it too. Yeah, I know, there's too much noise, but you actually can hear a click or a plop oftenly. Yeah? And in the worst case, it really can lead to a total dislocation or a luxation. Yeah? Then we have the active subsystem. And the active subsystem, we're speaking about muscles around the joint. And muscles can be classified as stabilizers or as mobilizers. And especially the stabilizers are very important for joint stability. Because muscle contraction of the stabilizers surrounding the joint causes compression forces, and that improves the stability of the joint, like shown here. Yeah? And then you have the mobilizers, and these are the muscles who produce power and lead the joint to move, like this. Okay? And then we have the neuromuscular control subsystem, which has actually a complex task of monitoring and adjusting the muscles surrounding the joint. And therefore, a concerted action between the sensory input and the motor output is needed to realign a joint. What we know, and this is confirmed by research studies in hypermobile EDS, is that each system of this can fail in hypermobile subjects, leading to joint instability. And physiotherapy cannot affect the passive system, not affect a ligament, yeah, but it can improve joint stability by training the muscles around the joint, so the active subsystem, and also the movement control subsystem. How should my physiotherapy sessions look like? Maybe first to say it's important to have physiotherapy sessions on a regular basis. We advise most of our patients to go to the physiotherapist 2 or 3 times a week. Yeah? To our opinion, manual therapy, exercise therapy, and additional techniques are altogether valuable. Yeah? I go more in depth now. Manual therapy helps on short term. Yeah? It can be of help to place the joint back into the correct position, and this is what we call joint alignment. And it also helps to decrease the pain caused by irritation of the joint capsule, the ligaments, and the nerves. Yeah? It can also be of help, on the right side you see this, to reduce pain in the global muscles by mobilizing techniques, by trigger point techniques, dry needling, etc. And also stretching of the global muscles is appropriate. I'll go to more in detail later. In a better phase, the combination of manual therapy and exercise therapy seems appropriate to us. Exercise therapy is essential to improve on long term, and it should focus on stabilization training in order to strengthen the muscles who need to stabilize the joint. Yeah? In combinations with exercises to learn you to have control over your movement and to move correctly. Yeah? And then we have the additional techniques such as taping and bracing, which could be of help to achieve joint alignment and stability, whereas TENS and heat, for example, have a more local and temporary effect on the global muscles. Okay. This one, okay. When we zoom in shortly on the manual therapy aspect, specifically the joint techniques, there is a scala of techniques that can be used by your physiotherapist. What I just want to say is that so you have very soft techniques and very hard techniques. The soft techniques seem, to our opinion, useful in unstable joints and in case of central sensitization, so widespread chronic pain. The mobilizations seem to help on hypermobile joints who are not unstable. And the manipulations are only applicable with care in case of an acute joint locking or blockage, and also not executed frequently, and are not applicable at unstable joints. Yeah? Okay. Next one, please. Yeah. Then we have exercise therapy. The types of exercise therapy we recommend are stabilization exercises to improve your core stability and your joint stability, but also movement control exercises in which you have to learn to move correctly. Also, muscle strength exercises of the global stabilizing muscles are warranted, but only if you have a level of local stabilizing muscles that is good enough. Yeah? Here you can see some multi or combined exercises, which I cannot explain in depth, but you can show these examples, of course, to your physiotherapist. And next to motor control exercises and muscle strength exercises, also stretching of certain global muscles is allowed, but only if it's meant to maintain or restore the length of muscles who are shortened. Yeah? Like example, the hamstrings are often shortened, the hip abductors, or if it's meant to reduce the hypertonia in muscles. Yeah? But be careful not to overstretch. Next question. Should my physiotherapist be more careful, and why? Yeah? Okay. Let me explain why first they should be more connective tissue is essential in your body for the normal organization and for the normal function of all your tissues in the body. Basically, what does it do? It supports, it connects and protects all of your tissues. Within the scope of EDS, collagen is of main interest. Yeah? And what does collagen do? It provides structure and strength to tendons, to ligaments, to fascia, to skin, to bone, and etc. Yeah? So genetic defects, they distort the structure of these collagens and resulting in many places in general soft tissue fragility at the joints, at the skin, and at other places. Yeah? So the main consequence of this tissue fragility for physiotherapy is the reduced load capacity. Yeah? And this is also leading to an increased risk for traumas, overuse lesions, inflammations. Also, we know there is a delayed recovery from exercise, and there is a very slow progress hampered by setbacks and flare-ups. So regarding exercise, and Jane already mentioned it, you and a physiotherapist should have prudence and patience. So general tips are start slow and go slow. Make sure you have enough variation in the exercise mode, so avoid too much repetitive movements. Space your exercise and progress only when you have success on a current level. This brings us to the question, which types of exercise are good and which ones not? What is not appropriate to do with patients with EDS or hypermobility spectrum disorder are this type of exercise because it causes more pain and more joint instability. These exercises are examples you should not start with, but maybe later on, after a lot of exercise, you might have a certain level of joint stability that is good enough, and then you can maybe move to these types of exercises. However, we see clinically that many patients with EDS or HSD will never be possible to do these types of exercise. So what is not appropriate? End range, so at the end of your motion, doing exercises there with an external load. In the left figure, you see the patient have a lot of pressure on her wrists, the body weight on it, and it's an end range of motion, so it causes more pain in the wrist and more instability. Also, too large range of motion, so too large movements, yeah, is not good. Yeah? This type of exercise on the right side is actually a quite good exercise, but the range of motion is too much, causing at the end instability and an inferior translation. Also, avoid open chain exercises. These are examples of open chain exercises, meaning that your arm or your foot is free in space when you do the exercises. Yeah? And I will show you what happened in this figure, like this. When you put an external load on it, the space in your joints gets even more larger, causing more instability. Yeah? Same for this type of exercises, for the gluteus medius, yeah, training for the hip stability. This is not an appropriate exercise. Yeah, same principle. Also, high-impact exercises, such as jumping, plyometric exercises, running, all exposing a very high load on the joints and is not appropriate to start with. So to continue, what is appropriate then? So perform exercises preferably in mid-range of motion, yeah? And these are good examples of lower limb exercises here. So the forward lunge, then destabilization, and then a step down, and so we can go on. Another principle is make sure that there is approximation of the joint. This means that the bullet is pushed into the ball, and this improves the stability of the joint. Yeah? And this can be realized, this approximation, by choosing closed chain exercises. Yeah? So your foot or your hand are on the ground or on a wall, so not in open space. Yeah? Or with body support, and these are good examples of closed chain exercises. If possible, exercise in warm water is an added value, though there are many benefits of exercising in water, such as a reduced or even no load on the joints, no sudden movements and accelerations, and some open chain exercises are feasible in water. Can I use tape, braces, and compressive clothing, and when should I use them? I will go shortly through this. Yes, you can use them. Yeah? Taping, bracing, and splinting helps to reduce the joint hypermobility, and it can help improve the mechanical stability of the joint, depending on the type of brace. Yeah? And also, it facilitates proprioception. And proprioception is your own sensation of where your joint is positioned in space. However, in most cases, we recommend not to wear the braces all the time, and only specific in these situations, during an acute or excessive pain episode, during healing after trauma, during specific intensive tasks or situations, and during the night, and this is more of prevention of subluxations. I added this slide because Jane also mentioned, these are silver ring splints. They are an exception of what I told before. These are dynamic type of splints, specifically for the fingers and the thumbs. These silver ring splints make you to move in a normal range of motion and not in the hypermobile range of motion. It gives stability, it reduces pain, and we confirmed this recently with a study we performed, and they can be worn all the time. Yeah? And the last part, which sports are good and which ones not? First to mention, in each sport, there are aspects which are good and aspects which are bad. Yeah? So again, it's very important to evaluate individually yourself and together with the physiotherapist and make choices depending on your own situation. Yeah? But to say something in general, these sports can be recommended. First of all, swimming, cycling, and walking, because these are sports with a minimal load on the joints and which are mainly cyclic movements without high peak forces. Also, Tai Chi, inline skating, and horse riding can be appropriate. These are sports which have a focus on balance and on movement control, and this is important. And also, certain devices in the gym or fitness are appropriate, certainly the devices in closed chain. And then which sports are in general not recommended? These are the high impact sports, also contact sports or sports with a high risk of falling. Also sports who aggravate the joint hypermobility, like dance and ballet. And also several other devices in the fitness or gym. Certainly the open chain exercises are not recommended. To end, I would like to mention what you can or should do as a patient regarding physiotherapy. I think it's important that you inform your physiotherapist about your situation, what the implications are regarding the reduced load capacity and etc. If you try to find a physiotherapist who really knows EDS well or hypermobility spectrum disorder well, it will take a lot of time. So I think it's better that you inform your physiotherapist about your situation. Please also have realistic expectation of what you can expect, as I explained, for physiotherapy. Also communicate well with your physio, but try to be condensed. I know there are a lot of problems, a lot of complaints, but try to be condensed. Yeah? It's your responsibility to exercise, preferably daily, if we speak about local stabilization training. Yeah? If you do not that, we cannot have an effect on long term. Also, use the braces properly and try to learn to protect your joints. So avoid harmful positions and avoid prolonged positions or repetitive movements. And my final thought is, although it is difficult, never give up. A special thanks to my colleagues of the clinic team Connective Tissue in Ghent. And also, thank you for your attention.